Wonderful. Well, thank you all very much. I'm sure we will have some other colleagues on the way, but what we've discovered with these webinars already is that actually the discussion is always really, really rich. So thank you for making time. It's a really exciting day today because we are actually inviting some of our main collaborators in other parts of the world to do these talks, and it gives me great pleasure to invite Adeniyi Olagunju, who I think probably doesn't actually need that much introduction to many of you. Adeniyi came to Liverpool for his PhD, and then he went back to Nigeria, did some more amazing work there, and including supervising a couple of other colleagues who are well known to our network, and then returned to Liverpool as a Welcome Fellow. He's now a senior lecturer in pharmacology, and he's very excitingly, he's head of the University of Liverpool Perinatal Pharmacology Group, which is a really exciting and young group. And as you know, if you know me at all, I think this is the most exciting area of pharmacology ever because it draws together a really neglected population. It draws together the complexity of the mother and the child and the baby and brings many aspects together. So today, Adeniyi is going to share some of his work, looking particularly at pharmacogenomics. I would encourage you all to ask questions, so make use of the Q&A function that you'll see at the bottom of the screen. It's better to use the Q&A for your questions because they stratify out more nicely. It's easier for us to make sure we respond. And yeah, please do continue to discuss this exciting topic, and some more of our colleagues, I'm sure, will join us on the way. So over to you, Adeniyi.
Yeah, thanks a lot, Katrina, for the very nice introduction. It's really an exciting time, especially at this time when the importance of this field of work is becoming clearer to everyone. So I look forward to sharing some of the things we've done over the last couple of years with the attendees. And I look forward to the interaction and follow-up. So just to start with acknowledgements, most of the things, all of the things that we've done actually over the years would be impossible without the support of wonderful colleagues in Liverpool. And before that, my colleagues at Obafemi Awolowo University in Nigeria, funding from Wellcome Trust, Tertiary Education Trust Fund in Nigeria, as well as additional funding from Wellcome, United, NIH that fund some of the work that we do in my group. So I lead the Perinatal Pharmacology group. This is the current face of the group. Carolina and Elenia are joining in January, just a month from now, but they're already well integrated into the team.
Adeniyi, I don't know if your slides are meant to be up. I'm not seeing anything at the moment.
All right. Can you see my slide now?
Not quite.
Oh, do I need to? Okay, let me start again. But you can see me, right?
I can see you. I can hear you. I can't
right.
see your slides. I don't know if anyone else can, but.
Oh, so I started sharing my slide. I thought the shared slide from the previous room would still be up.
Yeah, exactly. No, here we are. There you go.
Okay, so I need to
Thank you.
All right, good. Thanks for very quickly noting that. Yeah, so thanks again for the introduction. So this is the current phase of my group in Liverpool, and these are the previous affiliation that I have, Obafemi Awolowo University in Nigeria. Our colleagues there have been wonderful in terms of mentorship, as well as leading some of the important work that we've done, setting up infrastructure and so on. You'll see that as I share some relevant aspects with you. So this is the outline of what I will be talking about today. I'm going to start with the introduction, talking specifically on the importance of pharmacogenetics in women's health, sources of variability in drug response. And then I'll use case studies to highlight the role of pharmacogenetics in drug use during pregnancy and lactation. So women's health is very important to global health. As I'm sure all of you understand, women constitute 50% of global adult population. So if we're able to resolve issues having to do with women's health, we would have solved half of the issues that we have on this planet. Why this is so important is because most women take at least one drug during the course of pregnancy. And when you think about pregnancy, globally, 200 million women become pregnant every year. And in the vast majority of cases, they take one medication at least during the entire course of pregnancy. And when you look at a lot of these drugs, only 10% of them have adequate information about whether they are safe for use or not during pregnancy. So in other words, less than 1 out of 10 drugs that I use have definitive information about safety for use during human pregnancy. So you can see a very big gap there. And that really highlights the importance of this field. Now, one of the key things that is of interest to pharmacologists is how pregnancy affects drug metabolism. As pregnancy progresses from first trimester all the way to the third trimester, the baby is delivered, there are so many things that we need to think about. And this is mainly because of the hormonal changes that are associated with pregnancy. These three hormones changes significantly in the level that we find in the system during the course of pregnancy. And because they play one or two roles in the regulation of the genes that code for enzymes that metabolize drugs, then there is a consequence for the impact on drug metabolism in the course of pregnancy. And just to show you some examples, CYP2D6 as an example has upregulation of heat expression, and that results in increased activity during the course of pregnancy from the early weeks all the way to the time of delivery. The same thing is true with CYP3A4 and a couple of other enzymes. A few exemptions exist. For instance, CYP1A2 has decrease in activity during pregnancy, which is associated with decrease in the abundance of the enzyme. So these are the changes that take place when you think about enzymes that are responsible for drug metabolism, with significant consequences for drug exposure during pregnancy. So one key question that relates to drug use during pregnancy is, could this affect drug efficacy and safety during pregnancy? Remember that it's not just about the mom, but it's also about the baby. So with regards to the mom, if the level of the drug reduces during pregnancy, could that affect the efficacy of the drug? On the other hand, if it increases, could that have safety implications for the baby? On the other hand, would this vary between different genotype groups? And we'll touch on why genetics is very important. So these are the questions that come up when you look at the changes in hormonal levels during pregnancy and their impact on drug metabolism. Now let's talk a little bit about variability in drug exposure, generally, in whether someone is pregnant or not. Now I put up the example here of the antiretroviral drug efavirenz. So this paper published in 2008 really highlight very clearly the significant variability that we often see. For instance, the green bar, that's this green portion, that is what is expected. This is what you can refer to as the therapeutic window for efavirenz. So minimum effective concentration at the time was set at 1,000 nanogram per ml. Maximum was set at 4,000. But then in this population, this is what you find in this group of patients. So you see quite a few patients with concentrations below 1,000 nanogram per ml, and then you see a lot of patients with concentrations above 4,000 nanogram per ml. You have a patient here who has a concentration of 26,000 nanogram per ml. Personally, I've seen that in some of the studies that we've done in women. So this really highlights the significant variability that we often see when a drug is used in humans. Now, here is where it becomes interesting. These are I put this up just to highlight some of the sources of this variability and how these can become very important in pregnancy. For instance, here you see variability in drug response. and safety. This could be linked to pharmacokinetics. It could be linked to pharmacodynamics, right? And if you focus on pharmacokinetics, this could be because of drug metabolizing enzymes, that the gene coding for these enzymes has some polymorphisms, and those polymorphisms result in upregulation of the abundance of the enzymes and then increasing the activity of the enzymes. You could also have that at the level of drug transport proteins. So all of these play an important role. And where pregnancy is involved is you can have pregnancy directly impacting drug pharmacokinetics, maybe because of changes in for instance, blood volume changes in plasma protein levels and things like that. But you could also have impact of pregnancy at the level of transcriptional regulators, regulators that are important for these genes that code for these enzymes and these proteins. So you have hormones upregulated during pregnancy, and hence you have changes in these regulators. So this is how it happens when it comes to drug use in pregnancy. Now, let's think a little bit about a study that we've done in 2015. So what we did in this study was we tried to see if we can understand how much of the variability that we see in drug pharmacokinetics can be explained by genetics. These were the drugs that we had data for at the time, which included evaluants. What is interesting here is some class-specific distribution of the hereditary genetic contribution to drug, to variability in drug exposure. For evaluants, it was something around 80%. So in other words, around 80% of the observed variability in drug exposure is due to differences in genetics. And you see the same for nevirapine, the same for etravirine. And these are all non-nucleoside river transcriptase inhibitors. So there is a class-specific pattern. On the other hand, when you look at a drug like ratigravel, an integrase or strand transfer inhibitor, you see very minimal relative genetic contribution to observed variability. So what I have come to find over the last couple of years in different work that we've done in this area, perimeter health, is the fact that when there is a significant relative genetic contribution to variability in exposure, it is very likely that that will become important, not just in the general population, but also in pregnancy. In other words, pregnancy has its impact on drug metabolism, and you can have a reduction in drug exposure during pregnancy. And then when you put genetic factors on top of that, that could even be further accentuated. Now, let me show you what this could mean by using this hypothetical scenario. So this is an hypothetical scenario of drug exposure changes. So here you have on this axis, you have plasma HIV RNA, and then here you have ARV plasma minimum concentration. And then you have the time course of pregnancy in months highlighted here. Now, here you have scenario A. So these are three genotype groups. So here you have this patient, patient number 1, that is the red one. That's an extensive metabolizer of this ARV drug. And here you have the viral load. So this is the viral load in red, and then you have drug concentration in blue. So imagine this particular patient who is HIV positive, and the patient started treatment before pregnancy. And then this shaded portion is the period of pregnancy, right? She gets pregnant here. Remember, she's already on ARV. She's taking this drug. This is the HIV viral load there. So in this particular patient, this is the level of the drug. Remember, the patient is an extensive metabolizer, and so the level of the drug is low. So in the course of pregnancy, you can have a situation where the viral load is reducing, but then because the concentration of the drug is also reducing at the same time, it's affecting how much the viral load is getting suppressed. How quickly would you get to below detection? Or imagine this hypothetical threshold for maternal mother-to-child transmission of HIV. So this patient barely escaped. But now compare this to this particular scenario to a second scenario where the infection actually took place during pregnancy. So women get infected during pregnancy. She started ARV much more later. So you can end up with a situation where the viral load is not adequately suppressed below this threshold at the time of delivery. And most of the infections take place, that is mother-to-child transmission, most of them take place during delivery as well as during the postpartum period. So you can have a significant difference in risk as a result of these changes in drug exposure that is due to pregnancy, as well as the further impact of genetics if a woman is an extensive metabolizer of the ARV drug. Remember, this is an hypothetical scenario because the woman is taking not just one drug, but multiple drugs. But I hope that really highlights the fact that the risk is different between, or could be potentially different when you compare the two different scenarios. So that's one. You can have impact on drug efficacy depending on the timing of therapy initiation. Another important factor to have in mind is fetal developmental changes, as well as how drug can play an important role. Fetal susceptibility will depend a lot on the timing of exposure, and that is due to what you see here. Here you have the embryonic period from the 3rd week of pregnancy to 8th week. So week 8, you have the end of the embryonic period, and then you have the fetal period starting. So what injury a baby might be exposed to will depend on which particular organ are developing during that particular period. And it also depends on whether the fetal metabolic capacity is able to cope with some levels of exposure to the drug. Another important factor is the role of placenta. In some cases, the placenta play an important role in drug exposure and drug metabolism. In fact, there are drugs that wouldn't even be able to cross the placenta. And there are cases where the placenta has the metabolic enzymes and transporters for which the drug of interest is a substrate. So one important question that I put here is, could fetal genetics influence the extent of drug exposure? So that's one big question that we currently do not have answer to. So that's the foundation. So I'll now go on to show you some of the studies that we've done in the last couple of years. But before I do that, have in mind that exposure does not equate to injury. So the fact that the fetus is exposed to a certain drug does not necessarily mean that there is risk. In fact, it could be an advantage sometimes. But what is important to have in mind is the fact that the placenta is not just a conduit for endogenous and exogenous molecules, right? It plays far more important roles when it comes to the health of the baby and the health of the mom during pregnancy. In fact, there are cases where the level of exposure to a drug is very minimal, and the particular drug is associated with very poor pregnancy outcomes. On the other hand, there are cases where the level of exposure to the drug is really high, as in the case of nucleoside or reverse transcriptase inhibitors, and the drug has a very good safety record and very good pregnancy outcomes and so on. So that's really an important factor, point to have in mind. Nevertheless, it's still of interest to pharmacologists, perinatal pharmacologists in particular, to understand the extent of fetal exposure to maternal drugs. Now, let's now go to the case studies that I want to share with you. This is a study that was conducted in Benue State in Nigeria. Benue State is located in this part of Nigeria. So we carried out this study with funding from the Tertiary Education Trust Fund in Nigeria. It was published back in 2015 in CPT. So what we did in the study, we carried this study out in 2 stages. So in the first stage, we recruited a group of women and collected sparse PK samples during pregnancy. And the goal was really to see which particular polymorphisms in some candidate genes might be associated with drug exposure. And 2beta516G2T was found to be the one that was most significantly associated with evaporin's concentration during pregnancy. And you can see here the differences between the different genotype groups. So for instance, this is a group of women who carry two common alleles. And you have this group of women carrying a variant allele, and you have two variant alleles carried in this particular group. So significant differences in concentration. In fact, when you look at the multiple linear regression, for every variant allele that is carried, you have more than 1,500 nanogram per ml increase in the evaporin's concentration. So that was really very significant during pregnancy. And when you look at plasma concentration during the postpartum period, also similar. We also found very significant impact of this particular single nucleotide polymorphism associated with evaporin's concentration during the postpartum period. So we then carried on the study. We proceeded to the second stage, which was intensive PK stage. And for this particular stage, what we did was to then we re-enroll a subset of these women for the intensive PK phase. So we used the genetic data that we had from the first stage to select extensive metabolizers, intermediate metabolizers, and poor metabolizers. So this is the data for the pooled sample. So here you have all of the women who participated in the intensive PK phase. And what you can see very clearly here is you can see a clear difference between those who were pregnant and those who were in the postpartum period. So obviously it shows that pregnancy had a big impact on drug exposure. And when you compare the C-mean, which is the surrogate marker for efficacy, was 1,000 nanogram per ml, that is a median, compared to around 2,000 nanogram per ml in the postpartum group. So that's the summary for the entire population. And you can see increase in clearance, about 43% increase in clearance during the pregnancy period. Now, what is interesting is when you now stratify this population into different genotype groups. So these are women who had two alleles or who had two common alleles. There was no variant alleles. So these are those that you can refer to as extensive metabolizers. During pregnancy, this is the profile in red during pregnancy, postpartum. Again, you see a similar reduction. But when you look at the data more closely, you now notice that clearance is 100% increase during the pregnancy period. So you can look at that. So remember, when you look at the population as a whole, it was just around 60%, which is still a lot, but compare that to 100% in this particular group. And it's even more interesting when you now look at the C-mean. So C-mean is over 60% lower during pregnancy compared to postpartum. And when you look at the summary, the median is less than 600 nanogram per ml compared to more than 1,500 nanogram per ml during the postpartum period. In fact, this particular study really, it was surprising. We knew it was going to make an impact, but it was not expected that the impact would be so much. And what is even particularly of interest is the fact that we're talking of this concentration below 1,000 nanogram per ml in all of the women who were of this particular genotype. So 100% of them, none of them had a concentration above what was considered the minimum effective concentration at the time. Now, I'll summarize the key lessons from this particular study. So the first lesson is that at the standard 600 milligram dose, the 600 milligram daily dose of evaporins, the exposure was significantly less during pregnancy, especially in this group of participants. This study was cited in the 2016 WHO guideline for HIV treatment. as part of the reasons why pregnant women were excluded from the recommendation for reducing evaporates dose from 600 to 400 milligrams. The possible mechanism for this, why we did not empirically investigate this in the lab, but what is known is that during pregnancy, there is an increase in the concentration of 17-beta estradiol. And this is a strong inducer of CYP2D6. And that happens through this NR1I3, which is one of the transcriptional regulators for the gene that encodes CYP2D6 enzyme. So the level of induction depends on the inducible enzyme content, right? So when you have someone who carries the common allele, so there is a very high level of inducible enzyme content, and that then results in what we saw. So that's what we believe was the mechanism for what was observed in this study. But of course, we did not evaluate the impact of this on viral dynamics because these were women who have been on treatment for a long time. So in most cases, the level of virological suppression was already significant before the study was even started. So that's the first case study that I wanted to share with you. And we did some further analysis in this paper that was also published 3 years later in 2018. So we use population PK modeling to try to evaluate what will be the impact of a genotype-guided evaporates dose reduction in pregnant women compared to the universal dosing, whether with 600 milligrams or 400 milligrams of reduced dose. And this is the summary that is highlighted here. The C12 that is the concentration at 12 hours after dose was below what was recommended in the Encore-1 trial. This is a very important clinical trial that established the efficacy of 400 milligrams reduced dose of evaporates. And in that study, 470 nanogram per ml was set as the threshold for efficacy, unlike the previous popular 1000 nanogram per ml for efficacy threshold for evaporates. So the C12 in this population was below this level in just 10% of pregnant women at 400 nanogram per ml, and in 4.6% of these women at 600 milligrams. So when you look at that, it shows that if you give 400 milligram without consideration for the genotype, only 10% of pregnant women would have concentration below the threshold. But at the standard dose, then you reduce that number to 4.6%, just to provide some guidance. But when you look at the impact of genotype-guided dosing, it will be only 3.4%. So when you consider the genotype before giving the specific dose, then only 3.4% would have concentration below this threshold. And the toxicity threshold, which is 4,000 nanogram per ml, was exceeded only in 4.6% at 400 milligrams, but a lot more, 13.5%, exceeded that at the 600 milligrams dose. But when you use genotype-guided dosing, then you reduce that number, the number of women who would have concentration above the toxic level, you reduce it to 5.2%. So we contributed that after the main study was published. Now we'll move on to the second case study, which is more recently. This is a study where we evaluated the pharmacogenetics of evaporates exposure in cervical-vaginal fluid during pregnancy and the postpartum period. And this was of interest because when it comes to drug use during pregnancy for infections, especially infections that could potentially be transmitted on infectious diseases or sexually transmitted diseases in particular, what is important is not just the plasma concentration. The concentration in the fluid that are associated with transmission are also important. So we set out to look at the impact of pharmacogenetics on the cervical-vaginal fluid concentration of evaporates. The study was conducted also in Nigeria, funded by the word contrast. So I'll quickly summarize some of the data from this second case study. So we found a significant association between, again, the main enzyme responsible for evaporative metabolism, the gene that encodes it, CYP2B6 or 516G2T, was associated with cervicovaginal fluid concentration of evaporants, not just during pregnancy in CVF, but also in plasma. So the same trend that we observe in plasma, we observe a similar trend in cervicovaginal fluid. And the CVF concentration, because we're interested in seeing if there will be any difference between participants who had detectable HIV RNA in the CVF compared with those who did not. But we didn't really find any difference. So here you can see the plasma concentration, the CVF concentration in participants with detectable HIV RNA, just under 750 nanogram per ml, and under 790 nanogram per ml in those with undetectable HIV RNA. So there was really no clear difference between them. And the median HIV RNA in participants with detectable HIV was 770 copies per ml. Then the median evaporance concentration in participants with different thresholds of viral load. For instance, we looked at those with viral load above 1,000 copies per ml, and those with viral load, less than 1,000, and those above 1,000. Again, no clear difference. So both above 600 nanogram per ml was the concentration of the evaporance in the CVA. So there did not seem to be any impact. But remember that these are patients who have been on treatment for a long time. So that might be responsible for the reason why we couldn't find any significant differences. So let me show you the intensive PK data from this cohort. So here you see the CVF profile during pregnancy and the postpartum period. Again, just like plasma, we see the profile a lot less during pregnancy compared to the postpartum period. And when you look at different genotype groups, in this particular study, we were only able to assess participants who had the two common alleles, that's GG, and those who carried the two variant alleles. So you can see the massive difference in the Cmax. And of course, you can look at the overall profile as well. And just to show you the PK parameters in both periods. So during pregnancy, the AUC in CVF was 18 microgram hour per ml compared to 31 during the postpartum period. Again, a similar trend, similar to what was observed for plasma. In this particular group of women who contributed data for the intensive PK stage of the study, the HIV RNA was undetectable in all of them. And the median duration of treatment, like I was saying, was really long. So in this case, it was over 40 months at the time of sampling since they started antiretroviral treatment. So these are the key lessons. This was the first time anybody will study the impact of pharmacogenetics on cervicovaginal fluid exposure to any drug. And we notice a significantly lower concentration during pregnancy compared to the postpartum, and a trend towards higher accumulation during the pregnancy period. And clearance during pregnancy was higher, responsible for the lower overall PK parameters that we noticed. And the CME in CVF was exceeded the plasma protein binding adjusted IC90 that was established for evaporants. And that was important because it showed very clearly that even though pregnancy had a significant impact on drug exposure, but it looks like the efficacy level, well-established efficacy level, especially for Y-type HIV, was still exceeded. And again, this could explain the reason why there was no clear impact on viral load. So that's the second case study. I'll go on to the third case study now, which looks at another interesting aspect to drug use during pregnancy and lactation. And this has to do with prenatal drug exposure. How much exposure do we find in the baby? So what we tried to do here was to see whether maternal genetics and infant genetic factors were associated with drug use during pregnancy. The study was also conducted in Nigeria. First, we saw a very clear correlation between evaporative concentration in newborn samples as well as cord samples. When you compare newborn concentration and maternal concentration, we find a very good correlation between those two. The newborn plasma concentration, when we compare that to maternal concentration, was 0.8. So in other words, the concentration found in the baby was around 15% less than the concentration found in maternal plasma. But of course, you see very massive variability from 0.03 all the way to 3.49. So in other words, you have some babies who at the time of delivery had only 3% of what was found in maternal plasma, whereas there are those who had about 350% compared to what was found in maternal plasma. This is a summary of the differences between the newborns when you stratify them into different genotype groups. So these are women who are fast metabolizers, these are intermediate metabolizers, and these are slow metabolizer mothers. And these are the genotype groups of the babies. So when you look at that, you notice that babies born to women who are slow metabolizers always had much more higher concentration compared to those in the other two groups. And that's significant. And that was really something that was anticipated. And if you correct for maternal plasma concentration, CYP2B6 516G2T, that is maternal one, was still independently associated with prenatal drug exposure. We're really validating the fact that maternal genetics is important not only for maternal drug exposure, but also for fetal drug exposure level. And very quickly to the fourth case study that I want to show you. We've shown a similar trend for breast milk pharmacokinetics. And this is a study published back in 2015, where we showed clearly that just like you have genetics impacting on drug exposure in plasma, you see a similar trend in breast milk. And when it comes to how much of that drug becomes bioavailable to the baby is being breastfed, and the mom continues treatment of evaporative-based therapy. This was the analysis that we conducted to see the trend towards higher concentration in the baby based on different genotype combinations. For instance, here we use a combination of genotypes. So for instance, the GG that you see here, this is a situation where the mom is GG and the baby is also GG. So mom carried no variant allele, baby also carried no variant allele. They have the lowest concentration. And when you compare that to a situation where the mom had two variant alleles and the baby also had two variant alleles, so you have the highest concentration there. So you have increased trend, a trend towards higher concentration of evaporins in breastfed babies, depending on how many variant alleles are present in both moms and babies. So most of this work that I shared with you in these 4 case studies, they've been enabled by quite a lot of foundational work that I will refer to as enabling work. For instance, we've had to establish new methods for drug quantification by using minimal sampling strategies, because when you're conducting studies like this in pregnant women, nursing mothers, babies, it's really important to think of the fact that you simply cannot sample too much. You cannot collect too many samples from this population. So the study has to be as simple as possible. So to enable that, we've developed some minimal sampling strategies, dry blood spot method, dry breast milk spot method, dried cervical vaginal fluid swabs, and so on, to enable some of these studies, which were actually conducted in rural clinics where collection of plasma, freezing it, transporting it would have been totally impossible. And these are just examples of some of those papers where we reported those studies. But in addition to this published enabling work, there are also unpublished enabling work. And just to illustrate what that means, some of the work were done in Nigeria, and to enable that, we had to get mass specs, right? We had to get mass specs, and Professor Sekou in Liverpool really facilitated the donation of 2 mass spec systems to our laboratory in Nigeria back then. And here is Professor Bolaji, whom some of you might know. He's really a very good mentor who facilitated a lot of the work that we did on the ground, the establishment of the laboratories. Professor Andrew Owen, who is based in Liverpool, who provided training when I was being trained for my master's and PhD. So without all of this, it would have been possible to do the things that we've done. And I included the additional pictures. So here is a picture of the mass spec right after it was delivered, shipped from Liverpool to Obafemi Awolowo University in Nigeria. This is a picture of when we unboxed it, and this is a picture of when we're almost done with the installation. But in addition to that, we installed the mass spec. Now we need to worry about power supply. So we had to install a solar inverter system. So this was the installation of a 10 kVA system. These are the solar panels. I actually put this picture of Google Maps. So if you look for the Faculty of Pharmacy of Obafemi Awolowo University in Nigeria, and you look at the street view, you're likely to find this picture. And this is Professor Bolaji supervising some of the installation. So I thought I would share that with you just to show that working in a setting like the ones that we worked in really required doing some enabling work to make all of those things possible. I'll skip some of these additional slides where I highlighted the importance of the in silico modeling approaches that we currently use. And just to conclude, this is an integrated program of work that is currently going on in my group, really to bridge the gap between drug exposure and safety and efficacy. Because like I mentioned previously, it is not just about drug exposure when it comes to pregnancy. Exposure metrics alone are not enough. So we're doing some important work funded by Wellcome Trust to really begin to look at the safety implications of drug exposure. And this is one of the earliest early output from the program, PK Archive, which you can access at pkarchive.org. We launched this less than 2 weeks ago, and I would encourage you to visit the site, which is meant for sharing individual level PK data globally. And these are some additional initiatives that are going on here in Liverpool. I particularly want to highlight this one. We're developing a community of practice for long-acting therapeutics in maternal and pediatric health. So I thank you for your attention, and I'll be happy to take any questions that you may have. Thank you.
Absolutely fantastic, Adeniyi. I knew it would be, but again, I always find it wonderful to listen to these very clear case studies, very clear examples of why this matters. So I would encourage you to please either raise your hands or put questions in the Q&A. And I'm going to start by asking a question. I've just come straight from a webinar on TDM and low and middle income countries. So I would be interested to know if you could measure one thing in a patient, because obviously we can't always do what we want, everything we want. If I restricted you to one blood test, would you prefer have the genotype or a PK? Have I frozen? I've frozen or he's frozen.
You're back now, Katrina.
Am I back? Ah, internet. Sorry, I'm in Liverpool. It shouldn't be like this. Am I back? Adeniyi, did you hear my question? Can you hear me?
Katrina, we can hear you. It's your video that was frozen, but you're now back on both video and voice.
You can hear me.
Yep.
Cool. So Adeniyi,
Yes.
question: a PK or a genomic?
I think honestly, I'll go for PK, and the reason is because it's more actionable. And what I mean by that is in terms of capacity and translation. For me personally, having worked in a low and middle income country setting for a long time, it's difficult to see how you could personalize many of these things. So a general understanding of the PK, personally, I think it's important. Of course, if we're talking about drug exposure, I'll go for PK.
Right. And so what is the direct translation? Clinically, you've shown some fascinating data of how these different groups of individuals, some are subtherapeutic and they risk virological failure, and some risk toxicity, and that's all very clear. But what should clinicians or Ministry of Health, how should they take your work and sort of implement something meaningful in the clinic?
Thank you. So I think what happened with the recommendation for evaluating 400 milligrams, I think that's really a very strong, solid case study to highlight how meaningful some of this work could be. So while I personally struggle to see how pharmacogenomic could be translated more generally, I strongly believe that it could help us to really understand some, should I call it, some worst case scenarios of drug exposures. And if there are significant cases, for instance, if you look at a population in Nigeria as an example, and you know a particular SNP that is very popular, whether it is in women or more generally, and then you notice a major difference in drug exposure in people who carry this particular SNP, then you might want to implement something to be more careful, whether it has to do with reducing the dose or increasing the dose. So I think it's useful at a population level if the particular polymorphism that you're looking at is prevalent in a given population. You can make a decision based on that as a public health ministry of health.
Thank you. That you've obviously thought through this quite a lot, because it's often the question I ask myself. Fascinating, but how do we take it forward? Others, does anybody else have a question? I'm not seeing anything in the Q&A. Aha, Henry, wonderful. Maybe we can allow you to unmute, but the question is that given the growing importance of pharmacogenetics in personalizing therapies, how can the ex vivo perfusion assays contribute to our understanding of transporter function and drug exposure, especially in the context of perinatal health? What challenges do you see in translating these findings to clinical settings, particularly when accounting for genetic variation, placental transport, and fetal drug exposure? Gosh, a big question.
Yes, it is. Maybe we can break it down. So the first part is how can ex vivo perfusion assays contribute to our understanding of transporter function and drug exposure during pregnancy? So what is good about perfusion models is you can study drug transport at all placental level, right? So you can use, and some labs have the setup. You take the placenta and then you perfuse and then you look at how much of the drug is passing through. So you can do that, and that's a big advantage. However, there are problems with it because of mainly the viability of the harvested placenta is very short. So this is something you really have to do super quickly. And the question is, how much data can you get out of that? So that's one problem, the viability. The second problem is the fact that you're looking at time placenta in most cases. So it only gives you an understanding of drug exposure in the later stage of pregnancy. So it doesn't really tell you what you will find in previous stages. And if you're able to access placentas from earlier stages of pregnancy, could this potentially be due to pregnancy terminations or pregnancy loss because of a disease condition? Again, you wouldn't be looking at healthy placentas. So it's complicated. It's an incredibly complex system to set up. So it can give you some information, but you still have a lot of gaps that you still need to fill. That's why personally in our group, we're working on organ-on-chip models to resolve some of those challenges. And then the second part, what challenges do you see in translating these findings in clinical settings, particularly when accounting for genetic variations, placenta transfer mechanisms, and fetal drug exposure? So translation, like I was discussing with Katrina previously, I believe translation has to, there are two sides to it. Translation at clinic level might be a little bit difficult, a little bit challenging, because even in the most developed countries, genetics is not something you can easily integrate into health systems, because health systems have too many challenges they're coping with. So, but I think during the process of drug development or during the marketing phase, the early marketing phase of a drug, whatever we can understand